Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint AIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the AIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The AIIMS NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
Good afternoon, one and all. I welcome you all to today's AIIMS NAMS Navigate Medico CME program for postgraduates on a very important topic, which is autism spectrum disorders current update. I would like to welcome Dr. Umesh Kapil sir, who is the Secretary of the National Academy of Medical Sciences, to deliver the welcome address.
Thank you very much, Dr. Preeti. Just to introduce Dr. Preeti, she is an assistant professor in Department of Psychiatry at All India Institute of Medical Sciences, New Delhi. And she has been with us for almost last 2 years for all the Navigate CME program. And she is the coordinator for each of the CME program. On behalf of NAMS, it's a proud privilege to welcome all the participants, all the speakers, all the virtual participants, because this particular program is also on the YouTube. So welcome to all of you. The AIIMS NAMS Navigate program is essentially on the common topics which has been taken up by the most eminent faculty members in the country. We have speakers who have really achieved remarkable success in their clinical practice and in the field of academics. If we look at the country scenario, we have about 1.2 lakh MBBS students who come out every year, and out of which only 15,000, maximum 20,000 are able to get into their postgraduate program. Remaining, they keep on trying for the PG examination NEET, and they do not have the access to the best of the knowledge which should be given to them. So this program, what we have started is that is available free for everyone. Anybody can join and they can update their knowledge in the common areas which are relevant in their routine clinical practice, plus also prepare them for their postgraduate exams. All the sessions are the Recording of all the sessions is put on the NAMS website along with the PowerPoint presentation. Also, it's a virtual library. You can have a look of about 60 lectures have already been there. So anytime if some postgraduate has missed out a particular session, he can review it, he can get himself updated on that particular topic. So with these few words, I'll stop here and over to you, Preeti.
Thank you, sir. So, the NAMS, AIIMS NAMS Navigate Medical CMA program has been a huge success, and we have a lot of PG students joining both actively during the session and also through YouTube. Now, I would like to request our IT team, Mr. Ravi ji, to display the message from the President of National Academy of Medical Sciences by Dr. Digambar Behra, sir.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you very much, sir, for the introduction about NAMS and about the NAMS AIIMS Navigate Medico CME program. Now, I'd like to request our IT team, Mr. Ravi to display the message from the Honorable Director of the All India Institute of Medical Sciences, Mr. Dr. M. Srinivas, sir.
Namaskar. At the outset, I congratulate the team behind the NAMS AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you very much, sir. It is now my honor and privilege to invite Dr. Asifali Gulatri ma'am, the professor and faculty in charge of the Child Neurology Division from the Department of Pediatrics at All India Institute of Medical Sciences. Ma'am is also the program director of the DM Pediatric Neurology Program, and ma'am is a co-founder for this program in the year 2004, and she is also the adjunct faculty and at the National Brain Research Center. She is also the president of Association of Child Neurology India for the year 2023 to 2025, and she had been a founder member in 2002. Ma'am is also a national delegate of India and executive board member of the Asian Oceanian Child Neurology Association. She is the president of the 17th Asian Oceanian Congress of Child Neurology 2025, as well as International Society for Autism Research, first global senior leader in India. She is the editor of Autism Sage Journals, as well as a member of the IAIE Equity, Diversity and Inclusion Task Force. She is a convener of the pediatric subsection of the Indian Academy of Neurology, executive board member of the Indian Epilepsy Society, member of the advisory board of ICNTN, coordinator of the Neurodevelopmental Disorders Module, ICNTN. She has more than 400 publications, nearly 475 publications to her credit. She has a high Hutch index of 42 and I-10 index of 178. She is in the top 3% researchers globally, and she has published more than 600 abstracts and more than 900 invited talks. She is a recipient of more than 30 international and national awards, including the prestigious National Academy of Medical Sciences Women in Medicine Award, American Academy of Neurology, A.B. Baker Teach and Recognition Award, National Senior Women Bioscientist Award by DBT, National Award for Outstanding Efforts in Science and Technology Communication DST, Cedar Valleys Award, and Fellowship Award by Faculty of Medicine, McGill University. It's a honor and privilege to invite you, ma'am. Over to you, ma'am, for today's session on autism spectrum disorders current updates.
Thank you. Thank you, Professor Umesh Kapil and the entire NAMS for giving this opportunity. Can I have the other people not speaking have their mute, Yeah. So autism spectrum disorder current update. Basically, my idea is to prime you with what is happening globally, and it is not, it's nothing that negative about it in the sense that there is a lot of research which is going on globally and what we should know. I have nothing to disclose. Basically, I thought that the ASD prevalence is on the rise, so would like to, let you know what is happening about it, what is early diagnosis, and biomarkers for early diagnosis, early intervention, interdisciplinary management, pharmacotherapy in autism, and what is CAM, and what are the advances in management. Basically, it is a category of neurodevelopmental disorders which have problem in social interaction and communication. And the problem, how they also have a restrictive, repetitive patterns of behavior and interest, and they may also have sensory issues. What we need is awareness about the same so that we have a timely diagnosis, and we should understand that there are few comorbidities associated with autism spectrum disorder. So it has social interaction and communication issue, restricted repetitive patterns of behavior and interest, sensory issues, they insist on sameness, repetitive behaviors. They may have a cognitive impairment, they may have language skills which are impaired, they may have adaptive issues, But let me tell you, each child is different from the others. You have to take every child individually. You may have so many comorbidities which are listed outside: epilepsy, ADHD, sleep disturbances, irritability, GI disturbances, anxiety, depression, motor problems, and neuropsychiatric issues. So there are so many things which are there which we should be aware of, and the prevalence is actually on the rise. We initially it was thought around 1 in 1,000, but what happened is we did the incline study in 2011, and that time we had done for neurodevelopmental disorders, including autism as one of them. And that year we collected the data. I was the network coordinator for the same. Dr. Arora was the team leader, and we found the prevalence of 1 in 89. Mind you, this figure is of 2011 in India. And by population proportion by size sampling, we got a representative sample from for India. And CDC USA has reported it as 1 in 36 as of 23rd March 2024. And this is CDC 23 data, which they collated and published it on 23rd March 2024. And it is known to be 4.5 times commoner in boys than girls. Which is there over a period of years. There has been an increase in rise, which I will show you. So if you see, there has been a 312% increase in the ASD prevalence over the last a few decades. If you can see, since 2000 till now, there's a 312% increase. If your WHO has estimated around 1 in 100 children overall to have autism spectrum disorder. And this increase is not just increase awareness, which is looking as increase. No, in US they did all the conditions where you can be confused with autism, and they saw the prevalence before 1990s and afterwards, and they found a genuine increase. And you can just see that 312% since 2000. And another peculiar thing which is coming up, the ratio of male is to female, which was around 4.5 is to 1, is now becoming around 4 is to 1. So this is an important slide for you to understand. One is, you may have certain genetic factors. You have a lot of copy number variations. There are many genes which are identified, but you don't have a complete battery which has been identified, but there are copy number variations, point mutations, translocations. So CNVs become very important in this. Then there are environmental factors like viral infections, advanced paternal age, as well as maternal age, and zinc deficiency. We did a study along with Dr. Rima Dada, and we found that the fathers of children with the autism had certain methylation defects in the sperm epigenome. Then we also did one study with NDRI Karnal, in which we found that the gut microflora, the gut microbiome of the children with autism was different than that of their siblings. You eat the same diet in a family, so you expect the gut microbiome to be similar. So, besides this, environmental exposure to air pollution, which we have such a big problem in Delhi, in the pregnant mothers getting exposed to air pollution, the pesticides exposure for the pregnant mothers, all these things are really something, and that's why we are studying in AIIMS New Delhi. We are studying on both these aspects as well. We have a PhD dissertation going on to understand the toxins and the pesticides, and we have another DM dissertation which is started to try to study the air pollution. So all these things, and the epigenetic factors are something which is important: the DNA methylation, the histone modification, and the microRNA. Their environmental factors are going to express gene expression, and I personally feel that the epigenetic factors may be the game changer and provide us with some more therapeutic intervention targets in the future. So it's something that we have to see. For any condition, what we need is, we talk about primary, secondary, and tertiary prevention. Primary is that you have to find out the risk factors and prevent from its occurring. And, secondaries prevention is picking up early, and tertiary prevention is rehabilitating them. So this is a very busy but very important slide to understand. And I told you, on my personal belief, the epigenetic factors are maybe going to be the game changers in the years to come. Things like maternal diabetes have been shown in meta-analysis to have an increased risk to having autism. So we have not, as it clear, so we have had our own database along with IGIB, our database analyzed from IGIB. We have found many variants which have come up, which were not there in the Western literature. Now, what is the reality about early diagnosis? We keep talking about it now. This study from CDC. In CDC, they said that the median age at earliest known diagnosis was 49 months. Those who had intellectual disability, that means cognitive impairment, they were diagnosed early, 43 months. And those were cognitively preserved were diagnosed a bit later, at 53 months. So this was happening. This was happening basically at once. This was happening in the something happened to my screen once. Yeah, sorry. This was happening in the US. So you can you can always think what is going to be happening in LMICs like ours. So what is the prevalence? Substantial proportion are not getting identified under 6 years of age. Coming to AIIMS, we were getting patients around 4 years of age earlier. Then we started getting 2.5 to 3 years in the last 5 years. Now I'm getting patients even in the first year of life. So I recently have, you don't want to label somebody having autism, but recalling on or scoring on a risk on autism. So in an 8-month-old child, a child of a doctor started suspecting that there was some repetitive movement the child was making, and came to us, and that seemed to be, and that was the beginning of that. So you can actually suspect early. So now we are getting patients around 1.5 months in our outpatients as well. So timely diagnosis is important to improve the outcome of behavioral problems and the functional abilities and the communication issues which are there. So those things are, and you have to pick them up early to intervene in the critical period of development. As I mentioned to you earlier, those who are having preserved cognition and those who are having ADHD and in the underserved groups, they get missed and they, are diagnosed late. Current estimates are there that, we delay diagnosis by 3 to 5 years. And the common causes of delay are many times in Indian population, parents, the grandparents say that the parents were also sort of reserved and they will be okay when you go to, school, and when they mix with other, we have nuclear families, they're not interacting. So they just ignore it many times. And then, some ethnic minorities, families of low socioeconomic status, caregivers, some of the parents, they understand, they have a hunch and they're denying symptoms. There are many patients who come who have the children, when you examine, have frank features and you can feed the autistic features, but they're hell-bent on denying it. So, I mean, denial is a normal process. They are not doing it willfully. It's a normal process. When you come to know you have a really serious issue in your family, in your child, that is one of the issues, one of the steps before they go into acceptance would be denial. So in the denial, they want to go to multiple doctors and they will be liking the doctor who says the child does not have autism. So it's in that, sometimes they deny and they sometimes don't even come to hospital, or sometimes they'll go to 10. And even if one person says it is not, so they will stick to that. And that is something there. Then physicians are not identifying and screening appropriately. They are also missing it out. Limited availability of psychologists, and the caste family struggle for choosing appropriate treatment. And there's a lack of evidence for many supported information. And if you put the name autism spectrum disorder or even autism, you get 7 billion hits on the Google. So what are you supposed to read? You don't know what is evidence-based and what is not. So how and why are the delay? These are 2 papers we had published recently. And, in one of the papers, we found that there was a 1.5-year delay between the parental concerns in autism diagnosis. So that is why you recommended that we should have even non-specialist workers who are interacting with these families, like even those Anganwadi workers and ASHA workers, they should also be primed about this condition. There's another paper we published in which we found that it was important for community awareness and recognition, and very importantly, to reduce stigma. Many of my doctor colleagues have their own children and grandchildren having autism, and they do not want to share it. And I have many doctor colleagues, including from my department. They will come to my office and discuss, and some of them don't want even get children for therapies here or anything. They want to be go outside because they don't want to accept that. And so that is because of the, when you have somebody from an institute of national importance, such a senior clinicians thinking like that, then what will be the common community thinking? So that I shudder to think on that ground because of the attitude of lack of humanism in this community. They do not understand everybody who have typically developing. Nowadays you can't even say typically. Earlier used to say normal, abnormal. Then it became, typically developing, that is neurotypicals and special needs. Now you can't even say that. Now it is said that you should be calling them neurodiverse, like 5 fingers are different, and we were also in school, if you remember, there were many people who used to, there were 5 or 6 of them who were fighting for the top rank, and there are 5, 6 who are barely passing every time, and rest of them were in the middle. So you're accepting all of them, right? So you're supposed to accept all these neurodiversity also. So that has to be taken as a part of normalcy. So you can't call it neurotypical and special need. And they may be also variable phenotypes because they may be different patterns. Some of them may not manifest. Some of them may show in 12 months. If you don't respond to sound by your name at 6 months of age, when you have a normal hearing, and that may also be a red flag. But that somebody may not manifest symptoms in second or third birthday, or you may have some developmental regression later on, and the later diagnosed one usually have mild phenotype early. So you need to have research too for doing early biomarkers. Lots of research is going on. So then one thing more of our papers which we published with the global research of developmental disability collaborators was that you have a nurturing framework for supporting all children's care, and that should be we suggested that for children with developmental disabilities, especially things like autism, which goes into one of the invisible spectrum in LMICs, should be taken and important separately for 5 dimensions of responsive care, giving early learning, safety, security, nutrition, and health, like any child needs in the world. Then coming to early diagnosis and intervention, why is it important? Because during the first years of life, you have critical period of synaptogenesis. You have a peak synaptic density in the prefrontal cortex, usually by 3 years. There's neuronal dysfunction and overgrowth of connection in the frontal regions, aberrant neuroplasticity. And then neurofunctional outcomes for the toddlers with ASD should be optimal intervention as early as possible before these neuronal circuitries have completely formed. Both misdiagnosis and missed diagnosis are not uncommon. And you have to understand that what are the mimics, common mimics. You may have hearing impairment. A patient was referred to me of not having eye contact and all that, and the child ultimately turned out to be having hearing impairment. Although you may have hearing impairment, autism, but it was something you have to keep in mind. Having other neurodevelopmental disorders like intellectual disability, ADHD, communication disorders, developmental language disorders, and also, autoimmune encephalitis, epileptic encephalopathies can be there, and certain neuropsychiatric issues, including the anxiety, social anxiety disorders, having, post-institutional syndromes, etc. So you have to understand that there are many mimics which can masquerade. So we have to understand whether it is autism or no autism. It is really important for us to look forward about the same. So if you come to, there are things like which we should understand as postgraduates. You may have, you have things like LKS or ESS. So you have language regression and seizures. So in language regression occurs after 3 years of age in Landau-Kleffner syndrome, and there's a loss of receptive language. And the ESS is when you have, electrical status epilepticus in sleep, which is there. And I will show you in one of the EEG findings that you need, whenever you have a child with suspected autism or autism-like features with recent behavior issues, you like to have a sleep as well as an awake EEG, because in the awake, you may have a normal also EEG record. In autism, generally, the regression which occurs is generally before 3 years. It's generally 18 to 24 months. Generally, regression occurs. You may have seizures, and you may have isolated some discharges, maybe there in autism per se. But so you have to keep this in mind. Now it is called DESWAS, which is developmental or epileptical encephalopathy with spike wake activation in sleep. Just don't have to read the whole thing. Only one thing is you have various combinations of cognitive, language, behavior, and motor regression associated with marked spike in big activation in sleep. So the gist of it is you have to get a sleep as well as an awake EEG done. So this was a sleep record in one of these children whose awake record was totally normal. So this is important in this situation. On the contrary, when you're trying to differentiate, the ASD child will show those stereotypic movements, these movements which are there, the repetitive and idiosyncratic activities, echolalia and neologisms will be there. That will be there in more in autism children, so as to understand. So if you just try to remember, generally autistic regression in autism will be around 18 to 24 months, and it may be later on in the others. And you may have specific EEG abnormalities, like in LKS, you may have specific abnormalities related into the posterior temporal region. And ESS, I told you that you have to do the sleep and awake one. This was another child who was referred to as autism, but ultimately turned out to be, that the child, we get EEG done in autistic regression when you're having clinical seizures, you have unexplained encephalopathy or behavioral changes, or you have a progressive cognitive decline. This was a patient who was referred to us with seizures and autistic regression. And when we did the photic stimulation, we found a photoperoxysmal response, and then we could get the enzyme studies and then the genetic studies, and it confirmed a neurodegenerative disorder of NCL. So you have to keep in mind both ways. ADHD may get confused because 28% of autism may have ADHD as a comorbidity, and ADHD as such, if you're trying to differentiate between them, have no strict adherence to routine. They have attention issues. Cognition is usually better than ASD, but ASD may have high functioning as well as savant qualities also may be there in some of them. So you have an autism anyway. I mentioned to you how it is. Then you may also have different problem with social anxiety disorder, but then you have to understand that in autism, the anxiety comes with inability to communicate. So that is, and they're wanting to adherence to the sameness of the routines and all, which will not be there in social anxiety disorder. Coming to social communication disorder, again, that, this restricted, repetitive behaviors and fixed patterns of interest may help you differentiate between the two. The hearing impairment, yes, the same thing. The core features of autism may help you distinguish between it, but you understand that language delay may be complete in autistic features. And, for regarding language, there are three categories. Some of them who most of them are not going to be speaking much, have only some need-based communication, or they may be totally non-verbal as well. Some of them speak very less, but they may be rhyming very well. They may be, singing songs and have this, narrating the poems all perfectly well. And the third one are who are speaking normally and fluently, right? Hearing impairments does not have generally any problem with social issues and communication issues. Yes, that has to be kept in mind, but you have to also understand there's a double burden, that you may have the same genetic defect which is causing autism and which is causing also hearing impairment. So hearing impairments also, so you can have both ways. You have hearing impairment, you have autism, you have both of them together. And then, sometimes hearing impairment when untreated may have some autistic traits, and autism later on maybe, you may have issues there. They are not having problem in communication. So you will have problems in understanding whether they're hearing an issue. Coming to ID. ID is another difficult component. ID in the West, they say that around 40% of children with autism have cognitive impairment. But in our country, around 70 to 80% of children with autism have cognitive impairment. That's my experience. And in one of the trials, initially I had done in 2000s, I had done a trial on heavy metals, and from ICMR project, I had written that those with IQ of more than 70, I will be doing the quantitative EEG and certain tasks, whatever. In 1 year, I could not enroll any patient. So I had to write to them and remove and change my inclusion criteria for the quantitative EEG, and I had to write those who are able to understand the commands. So that is why I'm saying that it is very prevalent in our country. So the ID as such, maybe both they have verbal or non-verbal modes of social communications may be observed, but the content is limited in ID. And we understand the skill development, it's slow. It all deficits in all functional domains, and autism we understand. But we also should understand that in autism, when you see in the diagnostic criteria of DSM-5, the criteria E says that the disturbances are not better explained by ID or global development delay, because somebody who is having severe ID and global developmental delay may have issues in communications per se, right? So having those, those stereotypies and insisting on, sameness and all will help you in some situation. But it gets complicated in the sense that it's difficult to do cognitive testing and many times in autism. And it's also difficult to do full evaluation in somebody who is severely impaired in ID as well. And there are certain genetic conditions which may be causing both of them. So this complicates the issue. And that is why one should remember. And there is also, that's what said, there is a genetic basis of overlap of many of these conditions, including with ID. So, there are some 1007 risk genes which were identified in this paper, which was published in 2019. So now the genes have increased even much more than that. So there are many copy number variations which have been done, but we do not as such have any kind of a, we do not have any kind of a panel that if you do this and it's tested out. So what are the tools? What are the tools for screening and diagnosing in autism and biomarkers for early diagnosis? So you have a lot of international screening tools, but the commonest tool which all the people use is modified checklist for autism in toddlers, revised with follow-up in less than 3 years children, which is commonly used screening tool across India. It's used globally also, but across India. But for regarding Indian screening tools, we do have ASQ, which is ASQ is Ages and Stages questionnaire, which is from actually 0 to 40 for 0 to 4.5 years. But we have validated the 0 to 24 months. We've done an Indian adaptation, AIIMS adaptation with an ICMR project, and that can be used. And we have an AIIMS infant screening tool, which is from under 18 months of age. For the diagnostic tools, we do have the, you have the ADOS, which is doing a standard researches, and the childhood autism rating scale, which is being used very commonly pan-India. But AIIMS modified INDT is based on the DSM-5 tool, and I think that was the first tool published after the DSM-5 came up, and it's in consonance with ICD-11 of WHO. Now coming for preschool children, what is going to be important? So the important message which came from this Cochrane review was the accepted best practice for a preschool child is not going to be one single test, but it is going to be having a multidisciplinary assessment, including a pediatrician, a speech pathologist, psychologist, and then using all these tools available. So you have to have a, you have to have a holistically evaluating these children. This was a study I was mentioning to you about the 1 to 18 months AIIMS infant screening tool. And we have this in 0 to, we have 1 to 6 months, 6 months to 12 months, and 12 months to 18 months. We have 3 sets of 21, 20, 20 questions. And the sensitivity to pick up at 12 months was 90%, and that at 18 months was 98%. But then, we are using it as a screener. We are not labeling them at this point of time. Then we have this tools, DSM-5 based tool, which I mentioned to you, which also has very good psychometric properties of a sensitivity of 98.4% and specificity of 91.7, and also has a scoring, which is correlating with the CARS too. Now we need to have some biomarkers, though they are studying, trying to see that, if you can see as early as second year of life, if you're trying to understand the temperament and sensory processing. So they are trying to see whether there's some issues. So still it is in research mode only. So I'm just trying to really be trying to research mode. Then also there is general movement. This is the if your newborn is born, and the newborn has a you have a generalized activity. And a 1-year-old child is going to be able to have a coordinative activity and able to stand, and then later on start, and you can take a first independent step at 12 months. And, when we do this in the, in small children, this is general movement assessment. And we have seen it has been well established for predicting of cerebral palsy. But, for autism also many studies have taken place. And we are currently doing a study in which trying to predict autism as well as CP in these children, because of their general motor movements are going to be less. And this is going to pick them up early within the first couple of months of life. So this one is there. So this is what we are currently doing, and we are trying to do a home-based video and an in-clinic video and trying to compare and see the prediction. So this may help us, that the parents can be having their videos and we can suspect. Then there are some two tools which have been approved by FDA. This Cognoma for early diagnosis were approved by FDA in 2021, and it is from 18 to 72 months who are at risk. And this one has some questionnaire and also a video of the child which the parents uploads, and where because of the machine learning algorithm and all, they are able to say whether it has got autism not. This is the second tool which I was mentioning, that this came in July 2023. This is the US FDA's early tech, in which you are seeing this is for 16 to 30 months, and that one was 18 to 72 months. And in this, they are trying to see, show the children videos, and in response to certain videos, how the child reacts is how they are interpreting the various indices to see. Just priming you what all is going on currently. So many studies have gone on the home videos and the analysis of home videos of these children, and they're trying to predict autism. Also the gaze patterns, how the child looks around would be important to understand. And eye tracking is something also important. Currently in clinical practice, besides the research mode, it is being used to see in younger siblings of children with autism. And that is how it has been seen. It is said that these children are looking at the more socially inactive part of the face. So by gaze pattern and eye tracking patterns, there are lots of studies which are using the ML and AI-based algorithms to see. We have also done two such studies, in which we have developed, software in which we found that there were reduced number of anti-segates in the older preschool children. So we were able to see certain kind of, on the eye tracking that we could pick up early, but this was still in research mode, which we did with University of Birkbeck, London. So, and that there was also some studies which have shown, they have try to take various scales, different scales for analysis, and from there they have put some data points. So you take few points based on AI based algorithm, pick up the most helpful points, data points from the various scales, and try to get a consolidated picture, so as to apply the less number of instruments and less number of data points, and pick the children early. This we have developed with University of Manchester and Reading of UK. And in this, this is START, which is an advanced technology in ISD early diagnosis for 2 to 7 years. And we have already validated it, and it is working right now. So this is finished. This project is completed, and this is a mobile health based platform, and we expect it to be more used in the community. And this was a review, in which this review has shown, this review was done by our collaborators, in which they found that, you have a lot of gamified tasks, virtual reality platforms, automated analysis of video and recordings of behavior and speech for ASD risk. But still, whether we can actually have these digital tools ready for assessment is something we have to see. So, you hold, as I mentioned to you, you also have, many AI-based software they have made into a device, also trying to link all of these together to pick them up early. They are all in research mode. That is something important. And early detection using digital behavior phenotyping and analyzing by algorithm. But you should understand that this behavior phenotyping thing, we cannot just pick up a Cognova software from the US and do, because social culturally we are different. What is expected from our children is different from what is expected in the US or any other country. Everybody, these are all social cultural things. So we'll have to develop our own. So this is one more multimodal behavior analysis, in which we try to see children how they reacted to a humanoid robot. So we worked with Triple IT Delhi, and we had these Hindi speaking children interact with a humanoid robot. And what the interaction we found, we made through an ML, so we've developed a platform, the algorithm, and that is currently under patent, and it has also been published. So probably this will be one step in moving ahead with these, for whether we can have an early part. But the point is, these are obviously, robots are expensive. This is already under patent, and this is already published as well. There are a lot of early biomarkers, like, people are studying on some proteomic analysis of salivary biomarkers that may be simpler to do in committee, whether miRNA profiles can be done and all. So these are still in research mode, so they may be coming. So this is a January 2025 article also, in which they have seen They have just shown that this was a meta-analysis of various things, and they found that a lot of oxidative stress, mitochondrial dysfunction, problem which was there in these children. So there's a lot of this is going on, and these things, once we understand, may help us pick early and maybe helping as intervention targets. There are also some radiological studies which have shown some radiological abnormalities in these children, whether we can help to pick up early. There is also, you should remember that there are peak synaptic density in the prefrontal cortex, which is there. The peak it comes around 3 years. And then you have this remodeling and elimination. So you need to actually act early. That was the importance. So the American Academy of Pediatrics and Indian Academy of Pediatrics says that all children coming for immunization should be screened around 1.5 to 2.5 years for autism spectrum disorders. And they also say that, you can, if you, as I told you, that even at 6 months, you may suspect. So even if you suspect, even do this saying that if you're getting some biomarkers or if you have high risk, you can start this treatment, intervention, not treatment, intervention at 6 months of age, which they're calling it as pre-symptomatic. So there's lots of research going on. Other thing which is that the management is interdisciplinary, and we have to understand that interdisciplinary, that you have to have behavioral approach, speech and language, education, OT, sensory indication, psychologics to be seen, then the pharmacological treatment of the comorbidity, the core symptoms and the comorbidities. So this is something important. It has to be patient targeted, goal oriented. It has to be comprehensive. It has to have a short-term goals, long-term goals. It has to be dynamic, has to be tailored according to each and every individual. All children with autism are different. So this cannot be one size does not fit the all. It has to be customized. And the non-pharmacological therapy is primary and pharmacological is sort of supportive. And something is important is interdisciplinary. Because in multidisciplinary, everybody is seeing this child in silos. They're all separately seeing. What we want is they should interact with each other. So interdisciplinary is the way forward. And how early it should be early. Early is that you have to do it. That's why I said 1.5 to 2.5 years, they should have IAP, and IAP say they should have screening for all these children. So you have to be, start intervening before 2.5 years for maximum benefit. So then it is that if you have some, very high likelihood of developing ASD, depending on whether you have family history and all, then, you can also start, doing that from 6 months of life, as I mentioned to you. So the terminologies are that you should start early intervention at or before preschool as early as possible. 2 years or 3 years. The pre-symptomatic is what they call it like before 12 months. Preemptive is what they call it before 6 months. So, and how much early is beneficial? So that, earlier than 2 is going to be really beneficial in the long run. So that is something important. So this is something important that, what happens is many of the symptoms can be prevented if you have your stereotypies and your repetitive behaviors, which would not have developed that time when you become. So, those negative impacts are not developed on the functioning. So that is why it is going to be helpful. Then to when you have stereotypies and then you're handling it, it is a much tedious task. Yes. So they have shown that, if early intervention is more effective in reducing autistic symptoms and language deficits in children who were 36 to 47 months old versus those who were 48 to 60 months old. So that is why it is better that we have to do early. So diagnosis and treatment at a younger age. And as I told you, by 6 months of age, the effects will be very good. And the example will be there are many ways by which you have early intervention programs to improve their social communication skills for these children. And they should be enhance the development progression and improve, their interaction. So there are lots of them. ABA was one of them, which was most commonly used and based on operant conditioning, and there were debates have been there and controversies about it. So what you can ask any of the behavior therapies can be given, but yes, your sensory issues and all will depend, and you have to do, speech therapy, occupational therapy, and all will have to be done. This was another important paper I was part of. I was the only Asian in this paper in which, it was a global represented paper in which, if you see any paper study, you have data points. So, anything will come significant anytime. So because of bare numbers, you can ask any statistician. So what will be the delta change in CARS 2 will be taken as clinically meaningful. So in this elicitation, work which was done by us, it was decided as a group that it was concluded after this process, which was a blinded process, that a change of 4.5 points would be taken as meaningful. And this included people from different continents with different, cultural practices. So has a global implication. So there are a lot of studies which have shown that various behavioral therapies, like cognitive behavior therapy and many, many more, have beneficial effects. There are lots of studies going on one or the other. It is not the mandate today. My idea today is just to give an update that what is the situation, and the idea of putting the papers behind it, because only when there is evidence can some statement out of that evidence matter. So earlier the better, because of neuroplasticity, scope of research, and demands of large sample size of RCTs. You may have ABAs now under scrutiny because of long-term adverse effects have been noticed in that situation. So, you have prompt dependency, then you reliance on external reward system, and you may have, problem with the coping skills of denial and behavior disengagement. So you have many other naturalistic development therapies which have come. This is an important slide. This is our data, 1,872 children of autism, out of which 80% had one comorbidity at least, and 35% had more than one comorbidity. So it's very important to holistically see these children. Coming to pharmacotherapy, you may have pharmacotherapy on the core symptoms of autism, which may be repetitive behaviors, impaired communication and social interaction, or the pharmacotherapy of various comorbidities. This is the basic principles. Regarding for core symptoms, there is for the restrictive repetitive behavior, there is no FDA approved medical treatment which is there. Although for the core symptoms, you have risperidone and aripiprazole which have been used. So risperidone and aripiprazole are the only two drugs approved by FDA for treatment of pediatric patients with irritability and associated with autistic disorders and aggression. And clonidine has a promise to reduce the sleep latency initiation also, and nighttime awakening. And for inattention and all, methylphenidate and hyperactivity, impulsivity, methylphenidate and atomicity are useful. And sleep issues, when you have a sleep onset latency, melatonin and clonidine may be used for it. Also reduces nighttime awakenings. And for anxiety and depressive symptoms, they have some alpha-2 agonists have been tried. Coming to epilepsy, around 25% of them may also have epilepsy along with it. Epilepsy may be coming in three scenarios. You have a autistic regression is the first symptom in a child in whom clearly, epilepsy can be clearly diagnosed, like you have some spasms and all that. So obviously the diagnosis of autism along with epilepsy is clear. So you give anti-seizure medication. The autism regression occurs after repeated prolonged seizures. So you may obviously have to give anti-seizure medications to prevent some more, problems from happening, more seizures from happening. Then you may have, on the third scenario, you may have epileptic EEG are found in the child with autistic syndrome without history of regression. So basically that may be because the autism per se is also causing some structural changes in the brain, which is causing these EEG discharges. So then it has to be individualized, and it's a not clear indication for ASM just to have certain sleep abnormalities on a EEG with no frank seizures. So that will have to be individualized from case to case basis. In the world of precision medicine, yes, you are having some potential targets which are there. So if you have with tuberous sclerosis, you have everolimus, you have selumetinib with NF1, you have trofinidide with CDKL5, and also the RET is now out of the autism spectrum disorders, but it can also be used for CGG repeat expansion. The GAMT and you can use creatine, and that has to be kept in mind. It's important, when we did a sleep study, we found that 77.5% of our patients had problems on a sleep questionnaire. But when we did, it was very difficult to do all of their PSGs by making them sleep in the hospital, but we did. And we found that 100% had some problem on the PSG. Now we are doing a study in which trying to make a comprehensive module for management of sleep disorders in children with autism spectrum disorders, and trying to put the behavior intervention and the sleep hygiene, everything component together. It's a currently ongoing MD thesis. So the primary modality of autism is non-pharmacological. Drug therapy may help for some time, and they have some specific indications as I mentioned to you. And risperidone and aripiprazole are the only FDA approved ones. I did mention about comorbidities and anti-seizure medications. This is something important. We're just starting a study on seeing the impact of air pollution on children with autism spectrum disorder, because see, there is a lot of problems which caused by the air pollution. Now, just coming to the latest in early intervention are the digital advances which are there. As I also mentioned to you about the prevention, I have already mentioned to you about the various preventions. And we have, for early a lot of programs which have been developed, lot of technology based early intervention programs like this. The previous ones you have been developed. Some they are wearable digitable glasses. This was a sunflower superpower glass intervention. There are some Google glasses which was shown that it could improve the children's the emotions understanding. So this was the facial emotion recognition was improved by this. This is an ASD Toby in which they have again they have shown that they improved the adaptive functioning in these children. So there are a lot of people have started and done many studies in with digitally mediated social stories, virtual technologies, and all have been used. We have currently just we finished a study on randomized control trial we did on transcranial magnetic stimulation in children with autism spectrum disorder, and we did find that there was a improvement in the in these children with autism spectrum disorder after they were given transcranial magnetic stimulation. And there was a systematic review also which have shown that 3 studies had shown out of them. There were about 8 studies which we saw, and the 3 studies showed changes in stereotype behaviors. And there and in that and 2 studies showed a positive impact. So there are much more studies need to be done. And we had done only one time. We developed a protocol of theta burst pattern for doing the TMS in these children. It was established, but it was done in one set. Now we plan to do another study in which we may be repeating it after 6 months and seeing how it is going to impact the long term in these children. And this is one thing, CAM. CAM is a complementary and alternate therapies, which are 27 to 88% of families for autism use these therapies. And some of them have no benefit, some of them have possible benefit, and some of them have unknown benefit, but some of them may be harmful. So one has to understand that we should do. So out of the possible benefit is a gluten-free casein-free diet, music therapy, melatonin, oxytocin, TMS, yoga, and sulforaphane. And so that is something to be kept in mind. There are certain drugs which have come up, and nowadays cannabidiol has come up in a big way, and it is available in India, but it doesn't have any sufficient evidence right now. Sulforaphane has also come in India, still inconclusive results. And this cannabinoids, so it needs some long-term and outcome has to be studied. And they had reported that there was some, they have some improvements reported in some studies, but they really need preliminary work is there. L-carnitine has also been studied, oxytocin, but there are a lot of more studies to be needed. Ketogenic diet has been studied and shown that possibly may have some benefit effect. We are currently doing a modified Atkins in comparison to standard of care, because giving us ketogenic diet will be very less restrictive diet, and these children may have food faddism and may not like such restrictive. So in ketogenic diet, the most restrictive is ketogenic diet. Then you have modified Atkins, then you have low glycemic index. We've been studying on these various diets for the last 16 years and have over 13 papers on that. But for autism, we're just currently doing this as a DM dissertation. Regarding probiotics, as I mentioned to you, you remember that gut microbiome. I told you the children having autism had a different gut microbiome than their siblings. So we had to see whether the probiotics have some role. They could have theoretically. There's a very important gut-brain axis, and the GFCSF diet also can have a report as a significant possibility of a benefit. But they in the meta-analysis had not shown statistically significant. These are the 2 of my studies. I've just completed them. That one is a GFCSF diet, which is a positive study and showing that it is beneficial. And the other is a probiotics, which we picked up on 4 strains of probiotics, which were theoretically told from the literature that they'll be beneficial, and we got them developed, made. It's not a formal pharma preparation. We got it made, and it did not show much significant effect, although they we found that there were some changes in the gut flora. So we thought maybe longer study may be required for probiotics. For the besides probiotics, L-carnosine, vitamin B6 studies have been seen. Music therapy is something which is important, and there is a possibility of its helping, and there is a evidence for the same. They have found a positive effect, and we are currently doing one, just about to start the process of doing a passive as well as active music therapy in children with autism spectrum disorder. So there are a lot of interventions of art therapy, music therapy, and all going on in autism and many other neurodevelopment disorders. Wanted to end up by just talking about yoga therapy. Yoga therapy for children. Yoga is a mind-body therapy and shows promise in improving behavior, emotion, and sensory regulation in children with ASD. And the research shows that it causes increased neural connectivity, improved emotional regulation, and reduced anxiety. There is a neurophysiological basis. The slide is just trying to mention that it's not empirical. There is a neurophysiological basis of neuroplasticity, functional changes, stress reduction, autonomic balance, sensory processing, motor skills, cognition and behavior benefits, social and emotional development. Idea is just to tell that there are definite neurophysiological basis to it. And there are certain practical techniques which have been made for children. They are tried to modify and made them simpler poses for children, and then obviously you have to have those people who are the instructors have to be doing it individualized with them, and also mindfulness and meditation helps. And they have shown that for autism, in this study which was done from India itself, and this was an old study though on 2020, that better eye contact and sitting tolerance, better initiation skills, better self-stimulatory and self-injurious behavior, and increased social interaction. But the challenges are that these children have poor attention span. So then we can use visual schedules. You can use pictures and all to explain to them, make them structured routines, sensory sensitivities. Then you can adapt the mats which are there, reduce the auditory input because sometimes they don't want to hear loud noises, difficulty in following instructions. So you may use simple cues, break the whole process into different steps, give them social stories, give them photos, demonstrations, and you can have short structured sessions with visual aids, incorporate yoga into train routine, and the ASD specific strategies. And we plan to start something in the near future for the same. And something I wanted to mention was the screen time. Screen time, yes, I want to tell you that screen time has been shown to have issues, and screen time causes delayed language development, attention, social skills, sleep disorders, and increased anxiety. And yes, it has shown to be causing autism as well. So there are lots of studies which have shown that increased screen time causes autism spectrum disorder, and more the screen time, higher the risk it is. So we have to be very clear. Although this meta-analysis which was there, which showed that it was inconclusive because there were studies were not made in a similar properly way, but mostly they're showing that we have to take it that we have to reduce the screen exposure in these children. That is something very important. And it is shown that mixed screen types like phone, tablets, and computers show a strong association than TV and DVDs. There was something like virtual autism, which actually is a misnomer actually, but yes, this is definitely sure that intensive early screen exposure can have damages and has some physiological, biological mechanisms which are there. We have our website www.pedneuroaims.org. You can go to the autism drop down, and you can also go to the parents corner. And if you can also go to the academic corner. In the academic corner for residents, you have the developmental assessment, and you have the neurological examination, and you have the various videos how to do a development examination and a neurological examination. And you do have this app, the Ped NeuroAIMS diagnostic, in which you can download. You have tools for autism, epilepsy, ADHD, and neuromotor impairment. And neuromotor impairment includes CP, neuromuscle disorder, pro-stroke sequelae. This is the start which I had shown you. And we also had just completion of a randomized control trial of recording the interaction between the children and the caregivers, and then guiding them to improve them further. And then along with IIT Delhi, as a part of a center of excellence, we have developed certain softwares in which we are going to improve their spatial and temporal prediction skills for children with autism spectrum disorder. And we also developed virtual reality and augmented reality assisted joint attention training platform. This robot assisted thing I did mention to you what we have done for diagnosis. For intervention, we are just beginning to develop. And it's something there with the CDAC Delhi. We have just completed a project in which we have the brain-computer interface, trying to improve the communication skill of children with overall cognitive impairment, which includes children with autism spectrum disorder. This was one project of the DST which we did, and which a part of it we have done in AIIMS, in which we start to see the cap of children of knowledge attitude practice of the paramedics involved in AIIMS New Delhi, and we found that only 70% of them had good awareness. So we need to sensitize people, our own community. And with WHO, we're trying to develop a program in which, if you'll be screening these children, we're linking the screening and diagnostic tools, and we have made video-based interventions for the parents to understand that if you are screening and then you suspecting something, then you diagnose by diagnostic tools. Then the parent, if there's no risk, then they'll get the nurturing care video. But if there's some risk for autism, there's an autism related video, something for CP, something CP related video, so on and so forth. And this is something important as an editor of autism, when I get my rota of doing my editorial. So my first editorial I written was on neurodiversity and humanism in autism and LMIC healthcare perspective, because it's totally lacking in India. And then you have to encourage art and all. So we have this AIIMS THF collaborating center on the basement of our mother and child block, where we are trying to provide quality care, holding hand in magical years, what we have named it for these children. So earlier the better, because of neuroplasticity, early intervention versus pre-symptomatic versus preemptive, which was 6 months also. And pre-symptomatic was 12 months and early was 2 to 3 years. Scope of research, there is a lot of demand for large sample size. Primary modality of treatment is ASDs, non-pharmacological, but an ABA now is under scrutiny. Drug therapy can be used as a bridge, as a short-term therapy for settling certain issues which have come in time. The medications are targeted predominantly towards the comorbidities as well. And we have this Autism Awareness Month, which comes in April every year. Last year, it was celebrating the diverse spectrum of abilities. And to this year, it is My Positive Autistic Identity. So we need to have autistic awareness and sustainable development goals. I have to move towards equity, not equality. And I welcome you all to the 17th Asian Oceanian Child Neurology Congress in Yashimumi this year, 17th to 20th September. And on 16th September, we have 8 pre-conference workshops, including one on autism. You young people can register, can submit abstract. Abstract submission is still on. So you're most then welcome. You see, this is my institute where we've been there since 1988. And my team, which is there, an institute, and the institute foundation day. And this is on when we had for autism in 2015, we had the autism lit view in 2015. Thank you so much for your patient listener. I will be very happy to answer any queries.
I'll just check the chat. So if anyone has any queries or doubts, please post your questions on chat. As of now, there are no questions on chat, ma'am. If I may, I would like to ask one question. So, as a psychiatrist, we are seeing a lot of patients who are having autism spectrum disorder in our clinic. So we are definitely seeing the different ranges. So the one question which often comes during our clinics is that we refer them for the early intervention to definitely the pediatric neurology also. But what are the things that we can, as a clinician, tell to the patient's mother? Like, what are the interventions that they can do at home?
Yeah, we are also advocating home-based interventions as well. But like I myself cannot tell them various interventions myself. I will have to send to my therapist to do. We have made some booklets for parents. So if they want so we have made booklets for parents, and we have made various activities they can do. But that has been given to them by my psychologist and my other team, because we have a psychologist, we have OTPT special educator, we have audiologists, speech therapists, all of them are there. So, but I only tell them that these are the problem areas, this you focus. I direct to them, but which activity to do, I don't tell them grossly, except, few certain things for them to make the structure. The rest we will have to do that. We can work collaboratively. We can do something about it. Don't worry about that. But what do I mean to say? Ki, what exactly do I will not be able to tell myself. I mean, I can tell, but I will not have time. So even like it will be difficult. So they'll have to also accept. So we may have to do that. So we have made a structure, booklets and everything, and which we give them with pictorial English, Hindi, and when my therapist they tick mark on that.
Right, ma'am. There is one question, ma'am. Role of L-carnosine, the dose and how long can we try, and any diet restrictions like milk and sugar, etc.
Yeah, I said that see, no milk, nothing has been proven for milk and sugar and all that. One, L-carnosine also there is no evidence right now. We are not using it. I just mentioned it that because I wanted to say that these are being studied, these are being used and prescribed, but there's no evidence as of now for L-carnosine also. But I just presented that because I wanted them to understand that that these things are on and it's there. But still now, even that cannabidiol, which is now even come in India, which is now available, does not have right now evidence to, the evidence is not complete for that. So because what happened is that it's some improvement was found, but it is not right now. We do not have a significant improvement found over studies to use, for L-carnosine. So we are not using it. And I don't advocate it as of now. I think we need to have more studies to do it. Yeah, we should, because I felt GFCF diet should have potential benefit. And when we had reviewed, we did not find proper evidence. So we have created and generated evidence. We are just finalizing our study, and it is significantly positive. And no restriction. I mean, people will come to us with, chini band kar diya, doodh band kar diya, and all that. Gluten bhi band kar diya. So it's not that. I just because I just request to them, please let us just see the evidence, and that's why we made a lot of parent information booklets also, which are there on website as well, and we give to them. I said just let us look at the evidence and then only take a call. And because these are lifelong things, so it is not easy that then you can't just go on hit and trial to be done. And I mentioned to you as many as 88% of parents always try CAM. If you remember during COVID time, there was somebody who had written from Mumbai to the PM for camel milk, and then the PMO had provided camel milk. So there was no evidence for camel milk, but that time is no time to tell anybody. So, but that means it was very kindly provided from the PMO provided through from the thing. But what I meant, it just came on national headlines. So I was just thinking parents were fighting, and same thing. Stem cell has, I think I should mention, yeah, stem cell and hyperbaric oxygen has currently no proven role. Currently, we are also doing a study on stem cells. We are doing a study from exosomes derived from mesenchymal stem cells in ASD mice. But that's a animal model.
Ma'am, the same Dr. Kishore had asked for prebiotic, whether it should be given for the gut health.
See, Abhina, there between prebiotics and probiotics, lot of things are going on, and I think the questions have not answered. So that's why I think even my trial, which I'm not I'm just completed, there were some changes in the gut flora which came up, but there was not significant response. So I thought that we may have to go for longer duration and maybe try to do that prebiotic stuff as well. So there is something the people are also doing fecal transplantation. So I'm just saying that this area, the gut-brain axis, is something yes to be looked at, and I think the answers have not as yet come to put in clinical practice. So I encourage my parents when they are trying beta and trial. I always tell them in my counseling, please don't use something which doesn't have an evidence, because this is a lifelong problem, right? It's an issue. Just do not keep on adding stress to your child in a hope to do good. Try to help the studies and take part in the studies to generate evidence for the same.
Thank you very much, ma'am. If there are no more questions, now I'd like to request Dr. Ajay Sood, sir, the Deputy Secretary of the National Academy of Medical Sciences, to deliver the vote of thanks.
Thank you so much. On behalf of the National Academy of Medical Sciences, it is indeed my great privilege and pleasure to thank the distinguished speaker for this afternoon, Professor Shifali, for covering this topic very comprehensively, starting from the basic thing, then covering to the recent advances in diagnosis and management. Thank you so much, madam, for your valuable time. I'm sure that the tips which you have given to all of us, especially our PG student, regarding the management of autism will be very, very useful. So thank you so much for your support and blessing to National Academy of Medical Science.
Thank you, sir. Thank you.
I would
Thank
also like to thank all the senior faculty members, deans and directors from AIIMS and other medical institutions who have been supporting this program from the very beginning. And I again want to make a appeal. It is your own program. So please come forward. You can act as a faculty resource person. You can suggest us the topic and we will be happy to sort of involve you in this program. So this is your own program. Give us suggestion how we can improve it. I will also like to thank all the participants and the PG student in particular, because this is an opportunity where you can interact with the topmost eminent scientists and biomedical and medical scientists in the country, clinicians. So it is a very rare opportunity. So please do ask questions, and that will be really very beneficial to you as well as it will be helpful for better understanding of the topic which is covered. So I will also mention that the next session, which we have on 21st of March, is again going to be very, very interesting. It is on One Health approach in India, especially after the pandemic of COVID. This issue has come up that we should have an integrated approach, medical and veterinary and other sciences. So again, we have a very prominent, eminent scientist in the country, Dr. Pragya Yadav. She has kindly agreed to take this session on One Health approach in India. She is currently the officiating director in the National Institute of One Health, and she is also senior scientist at the Institute of Virology in Pune. And she was one of the key person who helped in the development of COVID vaccine in India. She helped in isolation of the SARS-CoV-2 strain, which later on was used in development of vaccine by the Bharat Biotech. So if you have any question, we will be happy to sort of request our speaker to answer those questions in the next session. So please do remember, this is going to be a very, very interesting session. Next session is on 21st of March. So please do join us. Another information for PG student is that in collaboration with the Indian Council of Medical Research, we have an online biostatistical helpline for the PG students for their issues related to thesis, so that how we can apply various statistical tests. So this is free, and the details are available on the website of NAMS as well as on the Indian Council of Medical Research. So you can register there, and senior biostatistician from NAMS as well as from the ICMR, they will be happy to interact with you. You can book your slot in advance and you can interact for as long as 30 minutes, and this session can be repeated. Another information is for those who are technology savvy. We have a course on artificial intelligence in health sector. This is again online certificate course of 12-week duration, which we have been doing in collaboration with the IIIT Hyderabad. The first session we had last year, and we had more than 142 students, PG student and junior faculty member who had registered. The next session is going to start in the month of March. And again, you can look into the website, NAMS website and IIIT website, and you can register online. This is again going to be very useful session, especially ma'am also mentioned in the future, artificial intelligence is going to play a very important role in clinical management of patients. And I would like to thank our moderator, Madam Dr. Preeti. She has been helping us from the very beginning. So thank you so much for your valuable time and the support to NAMS Academy. And we again look forward for this support to be continued. In the end, I would like to thank our IT team here, which comprises of Senior IT Officer Mr. Ravi and Mr. Shivam, who have been helping us in communicating with you and also organizing this Zoom session as well on the YouTube. And as our Secretary, Dr. Umesh Kapil sir mentioned, that all these sessions are available on our website. So in case you want to sort of again look into these topics, we have, as said, more than 60 topics which have been covered. And you can look into the videos, and also there are PPTs available and which you can use for the teaching and learning activities. So once again, I thank you all for being with us and making this session very, very interesting and interactive. Thank you so much. Over to you, Dr. Preeti.
Thank you, dear all. I declare today's academic session closed.
Thank you.